Good day, everyone. Good day to Doc Sia. We are group number five from Dentistry 5, and the members are Kagang, Cantero, Dueñas, Ebon, Felicio, Golparvar, Monteclaro, Momongan, Rubio, Perez, Bremonite, Tan, Chutor, and Ursal. So today we'll be talking about salivary gland diseases. So sit back and relax, and we hope you enjoy and learn something from our short discussion for today. Thank you.
Salivary glands are specialized glands in the oral cavity responsible for producing and secreting saliva. They are divided into two groups. Minor glands, they are numerous small glands scattered in the oral mucosa. Number two, major glands that they are large paired glands with distinct ducts. All the salivary glands develop from the embryonic oral cavity as pods of epithelium that extends into the underlying mesenchymal tissues. These epithelial ingrowths, or anlages, are apparent anatomically at 8 weeks gestation. As you can see, this unit consists of a kinous or secretory unit, which is a cluster of cells including myoepithelial cells and acinar secretory cells, with secretory granules that close into the collecting ducts, that include the intercalated duct followed by the striated duct and finally the excretory duct. Each ductal unit consists of unique acinar cells with branching ducts. We have three ductal systems. The first one is intercalated duct, second one striated duct, and third excretory duct. Each ductal unit consists of unique acinar cells with branching ducts.
The minor salivary glands are well developed and functional in the newborn infant. The acini of the minor salivary glands produce primarily mucus secretions. Between 800 and 1,000 minor salivary glands are present throughout the portions of the oral cavity that are covered by mucous membranes, with a few exceptions, such as the anterior third of the hard palate, the attached gingiva, and the dorsal surface of the anterior third of the tongue. Its in utero development is at day 40. So these are the well-established locations of the minor salivary glands. It is found in the labial, buccal, palatine, tonsillar or Weber glands, retromolar or Carmelt glands, and the lingual glands, which are the inferior apical glands or Blandin and Nunn, taste buds, Ebner glands, and the posterior lubricating glands. The minor salivary glands functions as lubrication and moisturization. They produce mucus-rich saliva that keeps the oral cavity moist, aiding in speech and swallowing. It also functions for protection. They secrete mucins that form a protective barrier over the mucosa, preventing mechanical trauma and desiccation. They also contain antimicrobial proteins like lysosomes and lactoferrin, contributing to oral defense. It also functions as taste enhancement. The von Ebner's gland secretes serous fluid to cleanse the taste buds and facilitate the perception of taste. They also aid in the buffering action and healing and immune support.
So now we're going to discuss the major salivary glands. So the major salivary glands are paired structures and it includes the parotid gland, the submandibular gland, and the sublingual gland. It develops in utero on day 35, and since it's a paired gland, the total number of glands would be 6. The parotid salivary gland is the largest among all salivary glands. It lies superficial to the posterior aspect of the masseter muscles and the ascending rami of the mandible, in an inverted triangle shape below the zygomatic arch, which you can see on the image on the left. It contains serous acini with few mucous cells. Serous cells are cuboidal cells with eosinophilic secretory granules and produce thin, watery secretions with low viscosity. The daily saliva production would be 25%, and the lowest viscosity saliva can be found here. The major duct would be the Stenson duct. Next is the submandibular salivary gland. It is located in the submandibular triangle of the neck, a triangle formed by the anterior belly of the digastric muscle, the posterior belly of the digastric muscle, and the inferior border of the mandible. The daily saliva production would be 70%, and the second highest viscosity of saliva can be found here. It is composed of both mucus and serous cells, and the major duct would be the Wharton duct. Lastly is the sublingual salivary gland. It is located on the superior surface of the mylohyoid muscle in the sublingual space and are separated from the oral cavity by a thin layer of oral mucosa in the anterior floor of the mouth. The daily saliva production would be quite low, 3 to 4%, and highest viscosity saliva is found here because it is composed mainly of mucous cells. The major duct would be the Bartholin duct.
Moving on to diagnostic modalities, we have patient history and clinical examination, salivary gland radiology, cyanoendoscopy, cyanochemistry, fine needle aspiration biopsy, and salivary gland biopsy. For patient history and clinical examination, these are the most important components of diagnosis in salivary gland disorders. So, clinical examination should include inspection and a bimanual palpation of the specific salivary gland with a determination of adequacy and normalcy of salivary flow, which may be accomplished through milking of the main duct of the gland to encourage drainage to assess the quantity and quality of the saliva produced. Next is salivary gland radiology. So under salivary gland radiology, we have plain film radiographs, cyalography, computed tomography, magnetic resonance imaging, ultrasonography, and positron emission tomography, and salivary scintigraphy, or the radioactive isotope scanning. So plain film radiographs are also called your two-dimensional radiographs. Its primary purpose is to identify salivary stones or calculi. So we have three plain film radiographs. These are the mandibular occlusal radiographs, the periapical radiographs, and the panoramic radiographs. So mandibular occlusal radiographs are most useful for detecting sublingual and submandibular gland calculi in the anterior portion of the mouth. Your periapical radiograph can show calculi in each salivary gland or duct, including your minor salivary glands, depending on the film placement. Lastly, your panoramic radiographs reveal stones in the parotid gland and may identify posteriorly located submandibular stones. Still under salivary gland radiology, we have cyalography. Cyalography is the gold standard in diagnostic salivary gland radiology because it can identify obstruction within the ductal system. It is also useful in the assessment of the extent of destruction of the salivary duct or parenchyma or even both as a result of obstructive, inflammatory, therapeutic, and neoplastic diseases. So cyalography can be easily performed under local anesthesia by doing the following steps. First is cannulation of the salivary duct, whether Stensen or Wharton's duct, with a plastic metal catheter. Second is injection of a radiographic contrast medium into the ductal system and the substance of the gland. And lastly is your acquisition of a series of radiographic images at various time points during this process. A complete cyanogram consists of three distinct phases. First is your ductal phase, which occurs immediately after injection of contrast material. Second is your acinar phase, which begins within minutes after the ductal system has become fully opacified. And the last one is evacuation phase, which assesses normal secretory clearance and elimination function of the gland. The next form of salivary gland radiology is your computed tomography, your magnetic resonance imaging, or in short, MRI, your ultrasonography, and your positron emission tomography. So, computed tomography has been generally reserved for the assessment of mass lesions of the salivary glands. CT scanning can demonstrate salivary gland calculi, especially submandibular stones that are located posteriorly in the duct or in the substance of the gland itself. The cone beam computed tomography, or what we call the CBCT, technology has been evaluated with regard to the diagnosis of sialolithiasis in the major salivary glands, and compared with ultrasonography, it was found to have high sensitivity and specificity. Your MRI is superior to computed tomography in delineating soft tissue details of salivary gland lesions, specifically tumors or other mass lesions, with no radiation exposure to the patient or the necessity of contrast enhancement. Your ultrasonography represents the most common examination method for nodular lesions and is useful to guide biopsies for diagnostic purposes. It has been also proposed as a complementary method for evaluation of obstructive salivary gland diseases. So the role of fluorodeoxyglucose positron emission tomography scanning has been examined in the assessment and workup of salivary gland malignancies for diagnostic and treatment planning purposes. It is also found to be clinically useful in both the initial tumor staging as well as in the accurate evaluation of nodal involvement by cervical lymph node level and post treatment evaluation, and also for monitoring for recurrences. The last form of salivary gland radiology is your salivary scintigraphy, or what we call the radioactive isotope scanning. It is the use of nuclear imaging in the form of radioactive isotope scanning or salivary scintigraphy, or what we also call cyaloscintigraphy. It allows a thorough evaluation of the salivary gland parenchyma with regard to the presence of mass lesions as well as to the function of the gland itself.
Okay, so now let's talk about salivary gland endoscopy, or also known as the cyaloendoscopy. So this is a specialized procedure that uses a small video camera, known as endoscope, with a light at the end of the flexible cannula. It is introduced into the ductal orifice following its dilation. So this procedure can be used both diagnostically and therapeutically. Diagnostically, it can demonstrate strictures and kinks in the ductal system, as well as mucus plugs and calcification under indirect visualization on a video monitor. Therapeutically, this procedure can also be used to dilate small strictures and flush small mucus plugs from the salivary gland ductal system. In addition, salivary gland stones located near the hilum, which are usually inaccessible from a transoral surgical approach, may be removed with a flexible endoscope and baskets, thereby avoiding removal of the gland, which is typically necessary with most posteriorly located or intrahilar stones. Since the initial introduction of endoscopy, advances have been made in the development of mini endoscopes, which has a diameter of 1.1 mm, with several ports for visualization, irrigation, and instrumentation of the ductal system. Specialized devices, such as a small balloon catheters, similarly used to those for coronary angioplasty procedures, can be used to dilate sites of ductal constrictions. Additionally, small metal baskets or mini forceps or graspers may be introduced into the duct for direct stone retrieval. Additionally, a small laser or lithotripsy device may be used through the endoscope to induce fragmentation of a large stone into smaller stones, thereby making them amenable to basket retrieval or spontaneous evacuation from the duct with fluid irrigation of the ductal system following lithotripsy. Salicylochemistry is an examination of the electrolyte composition of the saliva of each major salivary gland, which are the parotid, submandibular, and sublingual. This examination may indicate a variety of salivary gland disorders and systemic disease processes. The clinical importance of salicylochemistry has become more widespread, and some of these applications include endocrine functional assessment, drug concentration monitoring, antibody antigen measurements, and dynamic diagnostic testing. Principally, the concentration of sodium and potassium, which normally change with changes in salivary flow rate, are measured. Certain changes in the relative concentration of these electrolytes are seen in the specific salivary gland diseases. For example, an elevated sodium concentration with a decreased potassium concentration may indicate an inflammatory sialadenitis. Fine needle aspiration biopsy in the diagnosis of salivary gland tumors has been well documented. This procedure has a high accuracy rate for differentiating benign versus malignant lesions in superficial locations throughout the head and neck region. Fine needle aspiration biopsy is performed using a syringe with a 20 gauge or smaller needle. After regional local anesthetic administration, the needle is advanced into the mass lesion and the plunger is activated to create a vacuum in the syringe, and the needle is advanced back and forth throughout the mass with the pressure maintained on the plunger. The pressure is then released when the needle is withdrawn, and the cellular material and fluid are expelled onto a slide and prepared for a fixed histologic examination. This allows an immediate determination of benign versus malignant disease. This fine needle aspiration examination also offers a possibility of providing precise and accurate tissue diagnosis, especially if the oral and maxillofacial surgeon and oral and maxillofacial pathologists have excellent communication during the process and are experienced in performing and interpreting the results of this examination. A salivary gland biopsy, either incisional or excisional, can be used to diagnose lesions of major or minor salivary glands. It's also commonly used to diagnose Sjogren's syndrome. A lower lip labial salivary gland biopsy can reveal characteristic histopathological changes seen in the major glands of Sjogren's syndrome patients, avoiding the need for a more invasive parotid gland biopsy. The procedure is performed under local anesthesia. A small area of the lower lip is isolated and excised, removing 5 to 10 minor salivary glands. The removed tissue is examined histologically and a focus score is assigned. A focus is defined as an area of with 50 or more lymphocytes, histiocytes, and plasma cells per 4 millimeter square of tissue. The diagnosis of Sjogren's syndrome is supported by a focus score greater than 1, indicating the presence of one or more foci in the minor salivary gland tissue.
Salivary gland infections. We have necrotizing sialometaplasia and Sjogren's syndrome. Necrotizing sialometaplasia. It is a reactive, non-neoplastic inflammatory process that usually affects the minor salivary glands of the palate. However, it may involve minor salivary glands in any location. It is of unclear origin, but it is thought to result from vascular infarction of the salivary gland lobules. The usual age range of affected patients is between 23 and 66 years. Lesions usually appear as large, 1 to 4 cm, painless or painful, deeply ulcerated areas lateral to the palatal midline and near the junction of the hard and soft tissue palates. The appropriate diagnosis and management of this disease relies on evaluation by an oral and maxillofacial surgeon and an oral and maxillofacial pathologist. The ulcerations of necrotizing sialometaplasia usually heal spontaneously within 6 to 10 weeks after onset and require no surgical management.
So now we talk about the Sjogren syndrome. So a Sjogren syndrome is a multi-system disease process with a variable presentation. So there are two types: the primary Sjogren syndrome or Zika syndrome. It's characterized by xerostomia or dry mouth and a keratoconjunctivitis Zika, dry eyes. And also the second one is secondary Sjogren syndrome. It is composed of primary Sjogren syndrome and an associated connective tissue disorder, most commonly rheumatoid arthritis. So, in general, the first symptoms to appear are arthritic complaints, followed by ocular symptoms, and late in the disease process, salivary gland symptoms. The involvement of the salivary and lacrimal gland results from a lymphocytic replacement of the normal glandular elements. The Atomia results from a decreased function of the major and minor salivary glands, with the parotid gland being the most sensitive. So the treatment for Sjogren syndrome includes symptomatic care with artificial tears for the dry eye symptoms and salivary substitutes for the dry mouth symptoms. In addition, cholinergic medications such as pilocarpine or Salagen or biotin products may be useful to stimulate salivary flow from the little remaining functional salivary gland tissue represent.
Moving on to salivary gland neoplasms. This is divided into benign salivary gland tumors and malignant salivary gland tumors. Pleomorphic adenoma is the most common salivary gland tumor. In the major glands, the parotid gland is involved in 80% of cases. In the minor glands, the most common intraoral site is the palate. Pleomorphic, it refers to its variable histologic appearance containing a mixture of ductal epithelial cells and myoepithelial cells. The treatment for this is surgical excision, which is superficial parotidectomy or complete surgical excision with a margin of normal in uninvolved tissue. Warthin's tumor or papillary cystadenoma lymphomatosum exclusively affects the parotid gland, mostly the tail of the parotid. It is slow growing, painless, and a soft mass. It is associated with smoking and rarely occurs bilaterally. It is rarely symptomatic unless it compresses surrounding structures. It is believed to be caused by entrapped salivary epithelial rests within developing lymph nodes. Lastly, for benign salivary gland tumors, we have monomorphic adenoma. It is an uncommon solitary lesion composed of one cell type affecting predominantly the upper lip minor glands and the parotid gland. It is asymptomatic and freely movable. Treatment for this is simple surgical excision. Let's move on to malignant salivary gland tumors. First, we have the mucoepidermoid carcinoma. It is the most common malignant salivary gland tumor. This tumor makes up 10% of major gland tumors, mostly in the parotid, and 20% of minor gland tumors, mostly palatal. Submucosal mass that may be painful or ulcerated and may appear to have a bluish tinge because of the mucus content within. Treatment for this is surgical excision, and in most cases, we have to preserve the facial nerve. The higher the grade, the higher are the predominance of epidermoid cells and cellular pleomorphism, lack of mucous cells and cystic areas, and an overall more aggressive behavior. Polymorphous low-grade adenocarcinoma. This is the second most common salivary gland malignancy. From the name itself, it has many cell shapes and patterns. Most common site is the junction of the hard and soft palate. It has a high recurrence rate and treatment is wide surgical excision. Adenoid cystic carcinoma. It is the third most common intraoral salivary gland malignancy. It is a slow growing, non ulcerated mass with associated chronic dull pain. It is known for its slow growth, perineurial invasion, and tendency for recurrence and distant metastasis. Parotid lesions may result in facial paralysis as a result of neurotropism and facial nerve involvement. Basaloid cells are arranged in cribriform, like a Swiss cheese pattern. Treatment for this is wide surgical excision and in most cases followed by radiotherapy.
Obstructive salivary gland diseases. Sialolithiasis. It is the occurrence of salivary gland stones or calculi in the salivary gland ducts, often in the submandibular gland. The stones block the flow of saliva from the Wharton's duct, which is the longest salivary duct, leading to pain and swelling of the gland during eating or drinking. 85% of stone formation commonly occurs in the submandibular gland, mainly due to the calcium concentration and the alkaline pH. It is not commonly found in parotid or sublingual duct systems. It is twice as common in adult men and rare in children. and it is also commonly found in boys rather than girls. Submandibular stones are classified as anterior or posterior stones in relation to a transverse line drawn across the mandibular arch between the mandibular first molars. Anterior stones are well visualized on mandibular occlusal radiograph and can be removed by milking the gland with bimanual palpation or dilating the Wharton's duct with the same lacrimal probe. Posterior stones occurs in 50% of the cases and may be located at the hilum of the gland or within the gland itself. Intraoral removal is difficult in this case due to limited access. Refer to a oral maxillofacial surgeon to do a sialodocotomy.
It is sometimes necessary to remove the submandibular stones via an incision made in the floor of the mouth to expose the duct and the stone, or as we call this procedure, sialodocotomy. First, a suture is passed around the duct proximal to the stone to prevent propagation of the stone further toward the hilum of the gland. So a lacrimal probe may be used to locate the ductal orifice and to estimate the direction of the duct in the floor of the mouth. When the Wharton's duct is exposed, a longitudinal incision is made in the duct directly over the palpable stone. Once the stone is retrieved and the ductal lining is sutured to the mucosa of the floor of the mouth, a revision of the salivary duct is made where saliva will flow out and not through the original ductal orifice anteriorly, or as we call this procedure, sialodocoplasty. So with this procedure, the entire length of the duct is decreased and the opening created is much larger, the punctum is eliminated, and the influence of gravity leading to salivary stasis is lessened. A cannula may be left in the new ductal opening to prevent scarring and stricture. Regardless of the specific procedures, patients are still encouraged to maintain ample salivary flow by using salivary stimulants, such as citrus fruits, flavored candies, or at least glycerin swabs during the first weeks following the procedure. Another procedure is an extraoral approach to remove the gland due to repeated chronic stone formation, or as we call this, sialoadenectomy. It was challenged because it demonstrated that functional gland restoration after stone removal was found in 78% of the cases using scintigraphy, whereas 50% of the gland removed were normal on histopathologic examination. So, shockwave lithotripsy is a better alternative to sialoadenectomy in treating sialolithiasis by using electromagnetic techniques or intracorporeal using electrohydraulic, pneumatic, or laser endoscopic devices. So, the extracorporeal shockwave lithotripsy is the treatment of choice for all parotid calculi and submandibular, perihilar, or intraperchimal stones measuring less than 7 mm. It has not made into clinical application in the head and neck region because of several risks identified via in vitro studies.
For mucus retention and extravasation phenomena, we have mucosal and granula. Sometimes, when you accidentally bite your lip, you can damage the tiny salivary glands. This can cause saliva to leak into the surrounding tissue. Over time, this saliva can build up and form a little bump called a mucosal. These are most often found on the inside of your lower lip, but they can also show up on the inside of your cheeks. So, what happens is the mucus builds up under the skin, making it look kind of puffy and blue gray. It can even fill up with fluid, pop, and then fill up again. Sometimes they go away on their own, but if you keep messing with them, they may turn into a different kind of growth called a fibroma. The recurrence rates of mucosals may be as high as 15% to 30% after surgical removal, possibly caused by incomplete removal or repeat trauma to the residual minor salivary glands. For persistent or recurrent lesions, the preferred treatment consists of excision of the mucosal and the associated minor salivary glands that contributed to its formation to prevent recurrence in that same location. For lower lip mucosals, Regional local anesthesia is administered by a mental nerve block, and an incision is made through the mucosa. Careful dissection around the mucosal may permit its complete removal. However, in many cases, the thin lining ruptures and decompresses the mucosal before removal.
Ranula. The ranula is the most common lesion of the sublingual gland and may be considered a mucosal of the sublingual salivary gland. There are two types of ranulas, the simple ranula and the plunging ranula. For the simple ranula, it is confined to the area occupied by the sublingual gland in the sublingual space, superior to the mylohyoid muscle. As for the plunging ranula, it occurs when the lesion extends through and below the level of the mylohyoid muscle into the submandibular space. Ranulas are larger and less common than mucosals due to thicker overlying mucosa and less likely trauma. Plunging ranulas can extend into the neck, potentially causing airway obstruction, a medical emergency. The differential diagnosis of a floor of the mouth swelling includes ranula, lymphoepithelial cyst, epidermoid or dermoid cyst, salivary gland tumors, and mesenchymal tumors. The usual treatment of a ranula is marsupialization, wherein a portion of the oral mucosa of the floor of the mouth is excised, along with the superior wall of the ranula. The preferred treatment for recurrent or persistent ranulas is excision of the ranula, as well as the sublingual gland, by an intraoral approach in the anterior floor of the mouth. Several recent studies have indicated that this might be appropriate for initial therapy since the recurrence rate with marsupialization may be unacceptably high, especially in the pediatric patient population.
So we're gonna talk about traumatic salivary gland diseases, and we're gonna talk about its parts on traumatic injuries, facial lacerations, stents and duct repair, and its sequelae. So traumatic injuries, particularly lacerations involving the salivary glands and their ducts, may accompany a variety of facial injuries, including facial fractures. These are injuries that occur in proximity to one of the major salivary glands or ducts require careful evaluation during the head and neck examination. Shown in the picture is the parotid duct repair. Next is the our facial lacerations, which may involve not only the gland and its ductal system, but also branches of the facial nerve and branches of major facial vessels. These structures require meticulous assessment for appropriate diagnosis and prompt repair, if indicated.
Continuing on with the topic, we have the Stensen duct repair. So this may include a direct ductal anastomosis in which the proximal and distal portions of the duct are identified. A plastic or metal catheter is placed as a stent and the duct is sutured over the stent. To expound on a procedure, the catheter or stent is placed initially through the orifice of the Stenson duct intraorally and advanced proximally into the duct. Then the catheter or stent exits the duct at the laceration site. The proximal stump of the duct is identified and threaded over the catheter toward the distal stump of the duct and sutured to it. The catheter is usually left in place for 10 to 14 days to allow epithelialization of the duct to occur. In addition, facial nerve lacerations may require direct neural anastomosis performed using operating magnification to reapproximate the nerve stumps and placing epidural non-resorbable sutures. This is with or without the need for nerve grafting. And lastly is the sequelae. The potential sequelae of trauma involving the major salivary glands include infection, facial paralysis, cutaneous salivary gland fistula, sialocyl formation, and duct obstruction as a result of scar formation. This results in eventual glandular atrophy and decreased function. The involved non-functional gland may then eventually require surgical removal via superficial parotidectomy. So, a superficial parotidectomy is a surgical procedure that removes the top part of the parotid gland, which is a major salivary gland located in front of the ear. This procedure is performed to treat tumors that are confined to the superficial lobe of the gland, which is the part above the facial nerve. Once again, this has been group number 5, presenting the salivary gland diseases. Thank you very much, everyone, for listening to our discussion for today. We hope you enjoyed and we hope that you learned something from our topic for today. Thank you very much.